Welcome to COVID's Lasting Impact, Caring for Immigrant, Migrant, and Asylee Patients, a 10-episode mini-series within Migrant Clinician Network's On the Move podcast, a podcast dedicated to providers who work with vulnerable populations, specifically migrant populations. In this mini-series, MCN provides clinical teams, including community healthcare workers and primary care clinicians, with up-to-date information, expert guidance, resources, and relatable case stories for identifying, treating, and managing COVID and long COVID among U.S.-based immigrant, migrant, asylee, and limited English proficient patients in the outpatient setting. MCN is a national nonprofit with extensive experience providing timely, practical solutions at the intersection of vulnerability, migration, and health. Each episode provides clinicians with impactful tools and information for improving the quality of COVID care for vulnerable populations. If you want to hear future conversations on the topic of health justice, be sure to subscribe to the On the Move podcast. For resources mentioned in today's podcast, be sure to click on the link in our episode notes to go to our podcast page at migrantclinician.org/podcasts.
Well, welcome everyone to our podcast, COVID Testing, Treatment, and Management at the U.S.-Mexico border, Lessons Learned and National Impacts. I'm Liliana Garcia. I'm the Chief Program Officer of International and Emerging Issues for the Migrant Clinicians Network. I've worked there for many years, and so I'm responsible for an international case management and patient navigation program. I've worked in the areas of infectious disease, sexual violence, access to primary care, and have a deep and abiding interest in infectious disease control and prevention. So I've served as a principal investigator on a number of teams. I am really very concerned these days with the issues of migration and certainly what happens to people as they are in transit, either coming from their home country or as they're entering into our country. And I think that there's a lot that we need to learn about, and that we need to really be invested in understanding topics that may be emotionally charged for us or for us as healthcare providers. For this podcast, we have Dr. Roberto Johansson, affectionately known as Dr. Bert, who's a general and critical care pediatrician at Salud de Familiar La Fe in El Paso. We're going to be discussing the evolution of COVID care in an unfunded U.S.-Mexico border communities, strategies that have been successful in caring for patients, and important issues for the future of COVID and for other infectious diseases. Dr. Bert is board certified in general pediatrics and pediatric critical care, and presently, as I said, works for Salud de Familiar La Fe in El Paso. He's also a clinical associate professor of pediatrics at the Paul L. Foster School of Medicine at Texas Tech University Health Sciences Center, as well as having completed a pediatric residency at Children's Hospital of New York and Columbia University. He also did a fellowship in pediatric clinical care medicine at Cornell University. The American Society of Microbiology has awarded him an ICAAC Young Investigators Award, and he has been awarded membership in Alpha Omega Alpha and the Arnold Gold Humanitarian Society. He's authored a number of peer-reviewed scientific articles. He was also part of the Children Advocacy Committee in New York State for more than 20 years. And Dr. Bert is noted for employing children's play and humor as one method of evaluating his patients. Dr. Bert also works with children at the Center Against Family and Sexual Violence, recent immigrants, and with homeless children in El Paso. Welcome, Dr. Bert.
Thank you so much for having me. It's good to see you again.
It's good to see you. And so, I know that we've had a chance to speak before, but right now I wanted to go back and ask you to recall for me one of your first days when you saw COVID in your health center and what it meant to you in terms of what your practice was going to start looking like.
Well, it's interesting you asked that, because I also have a PhD in biomolecular engineering, and my work was done on influenza and viral spreading. My work was looked at how viruses can spread and how they get around immunology. So with that said, when I first started hearing about this illness, and I'm old enough to also remember SARS-1 and how it spread. So I was seeing, people coming in sick with flu-like illness, but I was also seeing patients in the hospital who were in respiratory distress and who required advancing help to help them breathe. And again began to realize that the patients I was seeing in the clinic could be divided into one of three groups. One who had not much illness going on, one where the illness was moderate, but they could stay at home, and that third group that needed hospital care. In that group that needed hospital care, there was a percentage that went into respiratory failure and died. And then later, we also realized there was some heart conditions and long-term COVID. So fortunately, the administration allowed us to open what we call pilot, a COVID clinic. So early on, what we did was testing. Yes, we had a shortage of available testing, but we were able to teach. We were able to get people to wear masks. We would get people to, when they were positive, stay away from groups. And that was in January of 2020. And as we evolved through it, fortunately, we had things like the monoclonal antibody. Mm-hmm. So I was able to tell patients, some of which had lost family members, don't worry, we have a treatment. And wow. Then as we moved into the treatment of the PO meds, that even made it easier because it gave us a wider patient base and we didn't have to depend on trying to get them to an infusion center. So, and then of course the vaccine has changed this dynamic completely. So I think there's a lot of people who are high up in our government and our healthcare system that deserve kudos. But for me, these young people who volunteered to come work with this crazy man in a clinic in the middle of Segundo Ovario to help our community, they're the heroes.
And so, you went through a bit of a progression. So go back for me, if you would,
okay,
to that very beginning piece. And as you were starting to see it emerge, and, what were the factors that were impacting people right there at the very beginning before you had a full-on sense of what you were grappling with?
Well, again, having a background, and indeed my PhD mentor was a guy named Ed Kilburn, who was an expert on the 1918 flu. I actually went back and read some things that he had written, and I captured that fear. I felt that, okay, my God, we don't have a vaccine, we don't have a treatment, and this virus kills. And to make it worse is the vast majority of people who got COVID, just like influenza, have a mild to moderate illness. So people go, oh, it's just the flu. Oh, it's just COVID. It's not a big deal. Well, a lot of elderly, we went through nursing homes, and I don't like the attitude, well, it's just old people. I happen to love my grandmother deeply. And, so that angered me. And then also we saw it in the young, the W-shaped curve that we also saw with the 1918. And I think the frustrating thing was, we had a shortage of tests. We had no treatment. There were false treatments coming out, hydroxychloroquine and others, IV Clorox. And yes, people were desperate. And I saw some people who were affected by that. As it progressed from a few people we were seeing in the clinic, we very quickly became overwhelmed with ICU beds and step-down beds. And we were essentially boarding people in our ERs. And it was frightening. But again, the real heroes here are the nurses and the MAs who came to work every day despite the fact they could get this virus and die. And they are my heroes.
Yeah. And you talked about, sort of the absence of sufficient testing, and certainly that we didn't have the vaccine in the early days. What other barriers did you encounter and that you were able to overcome?
Well, as you watch the news, there were people who were saying things that they really shouldn't have. And I became a little miffed because I always, I teach my children just like I was taught critical thinking. Who's telling me? And, a lot of times rather than getting, a world expert on virology and epidemiology, these people were oftentimes instructors or assistant professors in ER medicine or something else. And I would hear what they would say and be like, I know we need to let people know the truth and what's really going on. One of our biggest things was conquering the fear, the ignorance, the disinformation, and trying to build trust.
And what do you think made you effective at doing that?
Well, there were several things, and I'm glad you asked. Some of it was when they saw me out here, and then they would also see me in the hospital. They're like, both? So that built huge trust. Also, I am married to an El Pasoan, and you being from El Paso, that when people found out who my mother-in-law was, that bought that network. And it may sound silly to people who don't understand, but television, telephone, Telemexican. And she has been here for 65 years. Her husband was the only Hispanic. cardiothoracic surgeon in El Paso. So when she turned around and said, my son-in-law's smart and he knows what he's doing, it brought me into that community. And as silly as it sounds, it was a huge gain.
And so you got that gain early on with her. Now comes the vaccine. And what do you do then?
Well, again, we had a lot of disinformation, and, people always rushed and it was going on, not realizing that DNA vaccines, mRNA vaccines go back to the late 80s, 90s. So again, we had to combat the disinformation. I got accused of grandstanding because I got on television and got my vaccine, as did my mother-in-law and my wife and others, against saying, hey, look, if it's, we got it. And we did have to, I went to speak at church groups and community centers to get people to feel it was safe. And what was interesting is it got divided up into different groups. There were those who were lined up to come get the vaccine. They were waiting for us at 5:30 in the morning. There was the group in the middle that just needed a little gentle persuasion. And I respect that. And then there was that third group that, nope, they're never going to get it.
I mean, that third group, was the number in that group as significant as groups 1 and 2?
Here in Segundo Barrio, no, but there has been studies to show that in different areas, yes, it was very large. And I still run into people who do that. And, I've had patients, 2 people total, accuse me of giving them COVID when I tested them. So, there is that group. And again, it's, I think overall it is indeed a minority, but the size of it varies depending on where you are. And we know people have collected data on education, income, where you live.
Yeah. Well, but I think that the point that you were making is that, people saw you in the hospital and then they saw you in the neighborhood and then, your mother-in-law vouched for you, and all of those things that create trust are really important. And so with that then is a willingness to say, okay, here's someone who's concerned with me, which is, I think, what you're saying.
Well, fortunately, I'm blessed to work where I am. There's not a day that goes by that I don't look into a patient's face and see a relative or somebody and it's really very fulfilling. So I'm glad to hear you say that, because that's indeed what happened. You put yourself out and good things come, and it helped people.
And so now we're moving away from it being that everyone is really in danger of, some extreme health outcomes. It's moving more away from the hospital, I believe, and now becoming sort of a standard part of primary care. Do you think primary care is going to start managing COVID like the flu?
The answer is a yes, but don't let me stop there, because people say just the flu. And both as a primary care doc and as an intensivist, I can tell you flu's a killer. And it kills the most vulnerable, the very young, those who have underlying immunological problems or severe illness, and the elderly. And, in a non-pandemic year, flu kills 30 to 50,000 of our citizens a year. In a low to moderate epidemic year, that number goes to 3 to 5 million. And so to answer your question, I think, yes, people are going to say it's just the flu, it's just COVID, not a big deal. And then things get more complicated. I have a lot of patients refuse the influenza vaccine. Also, I think people also feel that since they can refuse it, they do. That mentality of a little control. And again, the belief that it's not severe. So I think we're seeing the same thing with COVID. Now, lying on top of that is reimbursement. We're seeing the same thing now with the RSV vaccines, where they cost like $500. And how long will a primary care physician or a public health or a hospital wait until they get reimbursed? Because they may lay out $10,000 to $100,000 and not get reimbursed for a year. So that was the complicated answer of yes. And I think we were a lot smarter now. Mm-hmm. I think we do have the vaccine. We still have treatment. I still give people Paxlovid and patients in the hospital. I've gotten a lot smarter about how I ventilate. And so I think we're in a better position, but I would like to plead people to please get the vaccine if they can.
And so, what you're talking about then is challenges on multiple fronts, right? You have the practice challenges, yes, how people are doing, and then you have the sort of convincing your patients or the educational problems. But then you're also talking about systems. I mean, reimbursement is a huge systems piece that I think is a challenge for lots of health centers and hospitals that serve a lesser able population than other places. And so I'm not sure what it is then that we're going to be able to do that overcomes that. Is that essentially the series of challenges that you see before you now?
Yeah, better articulated than I did. Absolutely.
But, I think a lot of things were well done when we were trying to address COVID. And I, so I would love to hear from you what you saw as well done when COVID came into play and others were trying to be responsive and provide what they could in terms of resources.
Well, actually, I think both the Trump and Biden administration did very well in getting, the vaccine out. And I also believe the Biden administration, in giving the monies to the communities, to the doctors, because, one of the things is like there was a local restaurant that I love here in town, Rosa's Cantina, that actually when it closed, it still hired its employees back to rebuild the place. So when they opened, it's still Rosa's, but it's new. And I think about that because that's a good example of someone getting the money, improving their business, but also keeping people employed.
So
as a
seeing those
consequence,
investments. Yeah.
exactly. And I saw that through Segundo Barrio. I saw it throughout places along here on the border where people were really, really industrious in building. Yes, I'm absolutely sure there were some people who just took the check and stayed at home and didn't do. But overall, what I saw was an investment in the community that I'm still seeing now. And I think that's wonderful.
It's really interesting because, there was all that debate all those many, many years ago about would it have been helpful if more people had understood about polio and the fact that Roosevelt had it, and but I think everything that he did around some of that and being engaged with those children and encouraging the vaccine was what helped so many people in my generation, and certainly me in thinking about my children. And so, I'm just wondering if there are some good things that came out in this COVID period that you think are going to help us moving forward with families and illnesses and prevention and preventive methods that we should take advantage of.
Oh, absolutely. I think little examples where that has grown. I also think that people have now become more aware of the importance of vaccination, the importance of certain symptoms. And I'm getting patients now who are entering me into a dialogue. Okay, I have COVID. What's my chances of long COVID? I had a discussion this weekend in the hospital with a patient who had read that if you take Paxlovid, the likelihood of long COVID is reduced. And, she's not a doctor or a nurse, but she had read this in a magazine. So I think that's something very important. What patients know has come up. And that makes my job easier. It makes it easier, especially in a community like El Paso here on the border, where, hey, I have these symptoms, and the grandmother's going to go, hey, you need to go see a doctor. And that's probably the biggest thing I'm proud of, because now I'm getting patients rather than in 8 or 9 day of illness where things start to get serious. I'm seeing them on day 3 or 4. And I want to take that into myocarditis, into pneumonia, into leg, whatever. I want to see my patients early. I want to practice wellness, not catch up sickness medicine.
Boy, that is great. Absolutely. I think that there are so many of us who either for our own personal sense of, oh no, I can tough this out, or for those individuals for whom money is a concern where they're like, I'm going to hold off. I really do think that discussion of wellness is going to be so critical. And I'm really glad that you're getting there. And so when you're looking at how COVID came about and the work that you did, what do you think going forward you want to tell new primary care providers coming in from their training?
Well, 2 things. One, don't ever stop learning. Get mechanisms, because people, it drives me, well, it's a short walk for me. It drives me crazy that doctors don't realize that we're part of an ongoing scholarship. And, I'm on the editorial board of a few journals, and I'm excited to see younger and younger, especially Hispanic authors now publishing. And I'm not saying go out and try to publish, but read, sit down and read a review. We have Pediatrics in Review, we have Prep ICU, we have the JAMA. So what's going on. Listen to the grandmothers, listen to the mom, sit on the floor and listen to your patients. I had a wonderful instructor, Dr. Megan Lawrence, who just recently passed away at 105, who Yeah, back in the 50s, she's the one who sat on the floor. She's the one who, played with kids to get the information out of them. And do that. Don't, and I do the same thing with the elderly. Come in, sit down, talk to them, ask them about their life in the past, develop that trust. And I know there are people who still think, oh, that's a waste of time. But as you just said, ACEs just showed us that the higher your ACEs, more likely to drink, more likely to use drugs, more likely to get in an abusive relationship, more likely to get pregnant, HIV, COPD, cirrhosis, and it keeps going. Because yes, there are immunological effects of having high cortisol. We know this. We also know stress leads to other things. And I think every young physician coming out and every young nurse practitioner needs to spend, I wish we could have ACEs time on every visit.
But the other thing is, I mean, those are folks coming out of school where there's still the ability to affect their practice. I really worry, now the conversation has changed. I know that for years throughout your whole practice, you've treated migrants, you've treated immigrants, refugee communities, people in need from Segundo Barrio and other places. But now there's the whole big discussion that the border has moved further north. And there's a whole field, a whole world of practicing clinicians who've not had that opportunity, don't know these communities, are seeing them for the first time. Where do we start with them? What's the first thing we ought to be telling these folks?
Well, the first thing to all those physicians, and indeed I do work a lot with my colleagues in New York and in Washington, D.C., take a deep breath and say the following words: I don't know. We recently learned during the Zika outbreak that a lot of the patients they were finding out who were born microcephalic or premature actually had a disease called Chagas. Chagas disease is caused by a trypanosome. You get bit by the reduvid bug, very special little critter, and it then poops on you which puts the bacteria in you. Mm-hmm. And it can result in problems swallowing, problems with your heart, as well as if you're pregnant, it can affect the fetus. So a lot of our migrants are coming from Chagas areas, which means they also have leishmaniasis, onchocerciasis. They also have dengue. So I'm going to go back to one of my mentors, Dr. Alan Ross, who always said, think about where your patient's from, both in socioeconomic group and their neighborhood. But did they come from another country? They're coming from Southeast Asia. Might they be infected with Clonorchis sinensis? They're coming from Egypt or some southern Vietnam. Do they have schistosomiasis? If they're coming from Central and South America, we need to ask about these tropical diseases. And now with things online, you can just Google it and get the information you need. But in order to make any diagnosis, you need to think about it. So my advice is, like Aretha Franklin said, stop, think about it.
You better think. And I think that's really wonderful. Exactly. Yeah, thank you so much. I mean, we wanted to bring this forward because we have been concerned in these last few years with COVID, but I think the populations are really changing. But the questions have always been the same. Where are you from and how are you doing? And where are you from socioeconomically, but also geographically, but also then family history wise, all of those pieces bring to bear. And those are really important points that you're raising. And I think that we have to look at the clinician through the whole life cycle of practice, right? We have our brand new folks coming out, but there are people who've been at this for a good time and really trying to make sure that they feel fully prepared. Thank you so much. I would just want to mention also that MCN has a project called Health Network, which looks to move people from one point to the next when they're traveling, but still keeping them in care to make sure that they don't lose any of those services. And there's going to be a lot of resources from this episode, including the original recording that you and I did when we had our webinar a while back. We do want to thank everybody who joins us to listen to this podcast. We really rely on you to kind of motivate us to keep moving these topics forward. And we really are grateful that you were here so that we could speak to Dr. Burt. And Dr. Burt, I want to really thank you for being here, for letting me talk to you again today. And for giving us all of this great information and your insights on what it's like to be really in the trenches and really within community, trying to take care of people.
And Del, thank you for being who you are and creating the environment that you do, and for protecting our new Americans, the migrants.
Always. Well, you can find out more about us on our webpage. And Dr. Burt, they told me it was okay for me to say that people could reach you by contacting you at roberto365@duck.com. So that's ROBERTO365 @duck.com. You can reach me at dgarcia@migrantclinician.org. For expert guidance and tools to improve the quality of COVID care for vulnerable populations, follow our podcast, On the Move with MCN, and come back and listen. Thank you.
To access resources mentioned in today's podcast, click on the link in our notes section to go to our podcast page at migrantclinician.org/podcasts. Visit migrantclinician.org/sign up to join our email list and subscribe to our blog to get updates on new MCN podcasts, resources, and webinars. Migrant Clinicians Network is a national nonprofit dedicated to providing practical solutions at the intersection of vulnerability, migration, and health. We offer technical assistance, health provider capacity building, resource development, research and data and evaluation support, and virtual case management for mobile populations, and free resources and training. The information in this podcast is for trained healthcare professional education only. Information should only be used in combination with up-to-date national and international guidelines. The information is not to be used as healthcare advice for the general public.